Thank you very much. It's an honor to be part of this symposium. And you may think it's too early for alcohol, but we'll get started with basically discussing our experience using cardiac veins as a therapeutic opportunity in EP, addressing some of the unmet needs in ablation of both PVCs and ventricular tachycardia. These are my disclosures. So I would like to divide this topic in two broad separate aspects. One, addressing LV summit ventricular arrhythmias, and second, addressing large VT substrates. These are very different technically, although we capitalize on the venous access to myocardial tissue to get the job done. So the LV summit has been recognized as a very challenging area to treat arrhythmias. This is hard to reach because of its anatomical determinants. You can understand the LV summit as the chunk of myocardium underneath the left main bifurcation. And as such, you could reach it epicardially, but the left main is right there, and the circumflex and LAD right there. So from the epicardium is really not a practical area. Also, there's full of epicardial fat. From the endocardium, from the right ventricular outflow tract, you could reach that. But again, you have myocardium to go through and the valvular tissue, as well as from the left ventricular outflow tract and the aortic sinus of Valsalva. We spent a long time trying to understand the venous anatomy of the LV summit. We looked at a lot of CT scans, and consistently there are LV summit veins, and from the coronary sinus you can reach them. However, there's enormous variability in the anatomical variations of the veins of the LV summit, and the fluoroscopic approach to image them is actually quite hard. After a long time and conversations with interventional cardiologists, we realized that if the LV summit is the myocardium underneath the left main bifurcation, we should use the projection that interventionalists use to display the left main bifurcation, that is the LAO caudal, or spider view. In the LAO caudal, you'll see open up the transition from anterior interventricular vein, great cardiac vein to anterior interventricular vein, and sequentially you will have an annular vein, a septal vein, another septal vein. These could be all targeted to deliver alcohol in the site of origin of ventricular arrhythmias. Alcohol in the coronary veins has also challenges from the standpoint of collateral flow that could be epicardial collaterals as well as intramyocardial collaterals, and that's important to understand when you deliver alcohol. So I think the best way to show how this is done is with an example. This is an 80-year-old man with palpitations and dizziness. These are these PVCs. And when we mapped his PVCs, you can see RV map, left ventricular map, and anterior interventricular vein map. The earliest site is arising from the transition from great cardiac vein to anterior interventricular vein. So that's kind of the hallmark of LV summit veins. Using, again, this schematic, we go to the LAO caudal, and we get venograms, and you will see there's a tiny, thin annular vein, there's a septal 1 and a septal 2. And then we set out to start mapping these veins. And now this is LAO caudal. You can see in LAO caudal, just to show here how it looks in RAO. In RAO, these are simultaneous venograms. You can see how in RAO, most of this vein is foreshortened, and it actually seems to go in backwards to the atrial area. So this vein did not have very good signals, so we moved on to map more distal veins. Here we're mapping the first septal vein, a little bit more distal, so this big septal vein. And in this big septal vein, we have a signal that is ridiculously early, 53 milliseconds before the QRS. And this is something that we've realized when we started doing this project, that when you map intramural veins, the standards of what's an early signal are completely different than when you map endocardium. When we're mapping endocardium, we're happy if we see a signal that's 30 milliseconds before the QRS or more. Here, the standard is radically different. Signals 50 milliseconds before the QRS are not unusual. So this is one example. You see 53 milliseconds pre-QRS signals with nice polarity reversal between adjacent bipoles. And the problem is the signal is collected from the middle of this EP star catheter. We have this large vein that you can see here. The EP star is in there, and the best signal happens to be between electrodes 4 and 5. So how do we go about treating just that segment of the vein and not the entire vein? So what we do is we put two balloons, one balloon for distal protection and one balloon for alcohol injection. That way, we restrict the alcohol in between the two balloons in the targeted segment of this vein. So we want to give the alcohol around this area and not anymore distal. It's technically challenging, sometimes time-consuming, sometimes impossible, but when you get this done, then you can deliver contrast and alcohol in between the two balloons only in that segment of the vein. This is the way it would look. You get some ugliness, some staining there. You can see the staining on ultrasound, and you can put it as part of the on cartosound. You can select the echogenic area. This is the way it looks. This is the targeted vein on carto, and when you deliver the alcohol, the PVCs go away. When you're in the right vein, this happens routinely. When you're not in the right vein, then obviously this will not happen. So you gotta get used to mapping more than one vein when you try this. What happens to the alcohol-treated area? If you do an MRI within 48 hours, you will see this is the baseline images. So the patient has some pre-existing delayed enhancement in the septum. But after alcohol, you see that we get these areas of darkness. So the opposite of enhancement, this is hypo-enhancement, if you will, consistent with microvascular occlusion. As the alcohol blows up the capillaries and delayed enhancement doesn't happen, contrast does not get there. We did a study trying to define the fate of alcohol-treated areas, and we first did an intraprocedural imaging with intracardiac echo. Now, the LV summit is a tough area to image on intracardiac echo. It looks ugly, but for the most part, you can see it as the areas between the aortic valve, left atrium, and this chunk of myocardium here is the LV summit. When you deliver alcohol, you would see intramural echogenicity. These are sequential examples of different patients treated, baseline imaging, and after alcohol, you can see the increased echogenicity that develops when you give alcohol in that intramural aspect of the LV summit. We did a series of patients where we had delayed imaging, so 30 days or longer after the alcohol was delivered, and we did 3D segmentation of the delayed enhancement areas, and we showed the scar was where you would expect it in the LV summit, as shown with 3D anatomical reconstruction of the MRI. Interestingly, the problem was that most of these patients had concomitant radiofrequency, so it's hard to discern what part of the scar belongs to the failed radiofrequency versus the intramural alcohol injection. Nevertheless, we did serial imaging with MRIs, and you see that after alcohol and radiofrequency in most cases, we had microvascular occlusion that on repeated serial MRIs, it would become later on a regular scar like any other with delayed enhancement. We tracked the progression of the scar. We saw that it decreased in volume, but had an average, overall final volume of the scar is of about 4 cc. So this is not a subtle ablation. Now, again, I remind you that most of these patients had previously failed radiofrequency, so we're computing the total scar size. There were no adverse events in terms of remodeling. The rejection fraction, if anything, improved after reduction of the arrhythmia burden and elimination of the PVCs that might have contributed to some of the cardiomyopathy. And we didn't see any evidence of ventricular septal defects or any adverse events chronically. Over the past, I would say, 10 years, we showed first the feasibility of LV summit vein mapping and ethanol ablation. We delineated the anatomy and came up with a schematic that has been very useful as a framework to understand the fluoroscopic anatomy and target different veins for mapping and ablation. We defined how to deal with collateral veins and the approach of the double balloon to restrict the alcohol to the targeted segment of the arrhythmias we were looking at. And occasionally we use alcohol in more than one vein, as I will show you some examples. And overall, in a series of 77 patients that had failed ablations before with radiofrequency, we achieved a 1-year success rate of 78%. So if we can eliminate 78% of the RF failures for LV summit, this is a very worth approach to consider. So I will move on next to using this approach to target large VT substrate in structural heart disease. This is just a list of studies looking at VT recurrence rate with standard ablation, with radiofrequency, whether it's endo or epi or combined. Usually you can see that recurrence rates can go from up to 62%, 13%. So we're not doing a great job in VT ablation in structural heart disease. And the most likely reason is intramural substrate that we don't reach with radiofrequency, either endo or epi. So the concept is very simple, particularly for ischemic VT. Wherever there's an infarct-related artery, just as embryologically happens, we have arteries next to veins. So there tends to be a vein next to every artery. Sometimes they're parallel, sometimes there's different veins, but most of the substrates will have, particularly ischemic, will have a substrate-related vein. And we can use this vein to deliver alcohol into the capillaries that drain in that substrate. So again, like I did before, the best way to show this is with an example. This is a patient with a previous LAD infarct, a massive scar in the left ventricle, and the scar is patchy. This is a voltage map. Please note the scale here, the 0 is the lower end, so I'm maximizing the display of any lower voltage areas that are within the scar. And of note, there's on activation mapping, there's an area of late potential, there's a conduction block here in sinus rhythm, and the propagation has to go around the scar, outlining what is a substrate of reentry with a very late potential mapped here in the apex. So what we do next after doing this map is we delineate the anatomy of the coronary veins adjacent or that correspond to the substrate. So here I'm injecting contrast in the anterior interventricular vein. I have a sheath all the way up here, and I inject contrast. The anterior interventricular vein seems to be rather atretic. This is very common in LAD infarcts. And as you can see, when I play this, the AIV comes here and has collaterals to the middle cardiac vein that will continue on here. And this is the middle cardiac vein opacified by collaterals. So this could be a problem because if I give alcohol in the AIV, alcohol will go through the collaterals to the middle cardiac vein and will bypass the myocardium. I want to treat the myocardium. So how do I go about restricting the alcohol so that it stays in the apex? So here, what I do is, in parallel, I put another sheath in the middle cardiac vein. The middle cardiac vein is being opacified, and late in the injection, you will see a collateral here. Let me play this again. A collateral here that goes to the AIV. Be patient, you will see, there it is, very faintly. It goes up to the AIV. So I will show it again. So what we do then next is to put a microelectrode catheter in the AIV and show it in the map. We need to show that the vein is in the scar to make it a legitimate target for alcohol ablation. So here we see the EP star catheter being displayed in the map. You can see how it's in the middle of the scar, of the low voltage area. This is an LAO cranial view. You can see it in an RAO view. It's right in the middle of the scars. Therefore, it is a legitimate target. More interestingly, remember I showed late potentials here in the apex? Well, let's see how those signals look like. So this is, again, a venogram with the AIV EP star, and this is the signal collected, call it Baylis because this EP star is manufactured by Baylis. You can see this late potential that matches what we had recorded endocardially. So now we go about injecting the alcohol. So what I do here is I have a balloon in the middle cardiac vein and a balloon in the anterior interventricular vein. We like to call it crossfire alcohol because we deliver alcohol through both. So I'm injecting contrast to the middle cardiac vein. This is the collateral that joined the AIV. And I have a balloon inflated here, so alcohol or contrast is restricted to the veins in between the two, in between the AIV and the middle cardiac vein. So then we give alcohol through the middle cardiac vein balloon and then the AIV balloon. Overall, as you give alcohol and you give contrast, you see this myocardial staining, which is a proof that you're delivering contrast and alcohol to the myocardium. So, okay, that's cool. Let's map after. So this is the pre-ethanol map. This is the post-ethanol map. Everything has become red, and there's no areas of patchy surviving channels in this scar. Look at the signals in the AIV, pre-ethanol and post-ethanol, the late potential is gone. We then finalize the ablation with radiofrequency to make sure that the standard of care is not compromised. We want to show core isolation, no late potentials endocardial, and lack of capture in the scar. This is an example of circumflex infarct and how we approach it. In the circumflex infarct tends to have more complex venous anatomy. This is one example. This is a large basolateral scar. The patient had VT in that area. We were able to map the entire VT circuit with a figure-of-8 reentry in this area of patchy low-voltage scar in the basolateral left ventricle. There's a big vein here, and please note that the voltage is actually normal here. This is more than 1.5 millivolts, so this vein is healthy. So it wouldn't be good to treat this vein with alcohol. But the nice thing is that that vein has lower branches that seem to go towards the low voltage scar. So here I have the EP star catheter in a lower branch of the vein. And by incorporating the location of this EP star catheter in the lower branch into the map, we define that it's in the substrate. I actually, to prove that further, I have the octa-ray catheter endocardially mapping the scar, as you can see here. And then I inject contrast, and I see that indeed this vein goes to the scar. So then we give alcohol in this vein. But we also find a more basal branch that also goes towards the scar. We deliver alcohol there, and then we see this new area of echogenicity that develops as we give the alcohol within the epicardial aspect of the low voltage scar. So this is primarily an epi-to-endo ablation. We actually map even further, and we found a lower lateral vein that is also in the scar. You see now the EP star catheter here in this vein is in the middle of the scar, so we also decide to treat that as well. Interesting, the EP star signals in there were relatively high voltage relative to the endocardium. For this vein, we did a double balloon approach and delivered more alcohol in there. And as you inject alcohol and then contrast, you see the myocardial staining, proof that you are delivering to the myocardium. You incorporate the echogenic areas that match the staining into the map, and you can see how we have new areas of echogenicity that correspond to the targeted areas with alcohol. The middle cardiac vein is what we use for RCA infarcts. RCA infarcts can be a little bit harder, and the middle cardiac vein is hard to engage. Sometimes we use the IJ approach to go from above. But this is one example, a patient with a middle cardiac vein infarct, low voltage area in the inferoseptal posterior wall, posterior basal. And when you get in the middle cardiac vein, it's rather healthy. Here we have EP star in the middle cardiac vein. We see all these branches going towards the septum. And what we do is a double balloon approach. Sorry, let me go back. A double balloon approach that requires often peripheral balloons. These are larger than the usual coronary balloons. These are 7 millimeter diameter because the MCV is quite big. So sequentially, double balloon approach, we deliver alcohol from distal to proximal, and as we deliver the alcohol, we see the staining of septal perforators going upward. And this is the map that we get after alcohol, consistent with polish or cleaning up the scar of residual signals. It's nice to use alcohol in post-LVAD VTs because, again, you have kind of carte blanche to ablate anything you want in the left ventricle. But this is one example where we can reach septal perforators with this approach. In non-ischemic VTs, this can be actually quite helpful as well. Of course, this concept of infarct-related vein doesn't apply to non-ischemic VTs, but suffice it to say, there are veins in every substrate, whether it's ischemic or non-ischemic. This is one example, a patient with sarcoidosis. Endocardially, there was no scar, maybe some basal low voltage area, but it's hard to tell when it's so basal. The epicardium had nice patchy lateral scar. And what we do again is to put electrograms, get electrograms and catheters in the veins. Here we have a decanav catheter in a large lateral vein and the EP star in a lower branch of this lateral vein. So now we need to incorporate this into the map. How is this vein located relative to this substrate? So we bring the map and we see the decapolar catheter is in a large vein, and this is the EP star in the lower branch that is right in the scar. So we go next, we put double balloon, deliver alcohol, and this is what we get. We get a new area of echogenicity that is incredibly nice and transmural. We can outline the silhouette of this echogenicity and put it in the map. This is the map after, and this is the map before, and this is the area of echogenicity. So we can get a really nice epi-to-endo ablation with this approach. For PVCs, particularly posterior superior process of inferoseptal substrates can be really, really tough, but it still can be doable. This is a patient that had PVCs arising from the posterior superior process or inferoseptal process, however you want to call it, or the crux, we used to call this before. Earliest signal measured in the middle cardiac vein proximally. Kind of hard to get to, but with a lot of effort, we got venograms of the middle cardiac vein. We found that there were septal perforators with a lot, no, let me go back. With a lot of effort, we get a wire in one of the septal perforators, followed up with a balloon. We inject, and here we have selective injection in a septal perforator. This is how it looks when we give alcohol. You develop this new echogenicity here that you can outline, put it in the map, and it matches exactly where we want it to target. Again, this is a proof that we can get alcohol delivered intramural. The key is to deliver it in the right vein. One thing we have noticed when we map epicardium versus the veins, we think of the epicardial mapping as the gold standard to delineate epicardial substrate, but there's a lot of epicardial fat that can actually muffle or obscure the signals from the epicardium. And what we are doing here is comparing signals from the epicardial surface obtained with the octarray and adjacent signals from a vein, a catheter inside the vein. The vein does not have epicardial fat obscuring the signals. So look at the decapolar signals here, nice late potentials recorded here, and simultaneously adjacent octarray signals. Maybe there's something here, but it's much less obvious than when you map the veins. So this is something we're learning, that sometimes vein mapping is better than epicardial mapping. This is another example, just skip this. So we took a series of 44 patients that had failed previous ablations. These are patients with substrate. 50% of them had non-ischemic cardiomyopathy, and 50% of them were ischemic. These were patients that in 2/3 of them were coming with VT storm and had failed previous radiofrequency ablation. So we subjected them to this approach, again, extensive. This is kind of labor-intensive procedure where we map the substrate, map the veins of the substrate, and treat the veins with double balloon, single balloon, one vein, two veins, depending on the individual substrate and in the individual anatomy. But with this approach, we achieve 74% success at 1 year. And you could argue that the late failures here could be related more to substrate progression than to procedural failures. When we look at the number of ICD therapies, whether ATPs or shocks, we had the dramatic decrease, of course, not a complete elimination, and a significant simplification of the antiarrhythmic regime required for these patients. We also did, like we did for the LV summits, serial MRI studies to see what is the fate of the alcohol-treated substrate. And again, it's very complex because these patients, by definition, already have a pre-existing substrate. But you can see this is a patient with a circumflex infarct treated with alcohol in lateral veins. Pre-existing baseline MRI had subendocardial delayed enhancement here. This is how it looks within 24 hours after giving alcohol in the coronary veins. You see this area of microvascular occlusion, kind of in different areas of the scar. Here we gave alcohol in a lateral vein as well as in the middle cardiac vein. And when you image patients later, this patient was meant to be imaged at 1 month, but he came 5 months later for the MRI. And you can see how the substrate has evolved to delayed enhancement. There's maybe still remaining some microvascular occlusion subendocardially, but you can see how the substrate progresses into a regular scar. This is a patient here with non-ischemic cardiomyopathy, suspected sarcoid but not proven, had a large basal lateral and mid-lateral delayed enhancement to begin with. This is how it looks after giving alcohol in lateral veins. 1 day after, you see the microvascular occlusion, this darkness in the long axis view as well as the short axis view. And on follow-up, you get partial conversion of this microvascular occlusion into delayed enhancement. There's some residual here, you can see there. This led to the design of the VELVET trial, where we're testing venous alcohol for left ventricular tachycardia. This after 2 years of work, finally we got NIH funding, and the idea is to take patients with ischemic heart disease and ischemic VT, and randomize them to endocardial catheter ablation alone or combined with alcohol infusion in the substrate veins. We're going to follow the patients 1 month, 3, 6, and 12 months with ICD checks. Obviously, the gold standard of the arrhythmia recurrence comes from ICD interrogation, so this is a relatively simple trial to run. And we're adding some imaging studies. It's a unique opportunity to have a randomized study of VT ablation. So we're doing a lot of imaging sub-studies to delineate the scar and the vein characteristics and innervation imaging characteristics. Let me speak a little bit about the innervation later. Primary endpoints is basically a safety endpoint and an efficacy endpoint. Efficacy is VT recurrence, and safety endpoints, this is a complex and risky procedure, so we want to look at death, hospitalization for cardiac causes, and procedural complications. A few words about the imaging. It's arguable the gold standard of imaging of a VT substrate is electroanatomical mapping, but more and more we're using CT and MRI to delineate those substrates. So I thought it would be a great opportunity to try to get MRI delineation of the substrate before and after and correlate the changes in the substrate by imaging with the endpoints. So we're doing MRIs. We're using ADA software to process the scar and to delineate channels within the scar. This is great when the image is good. It's not so good when the image is bad, but we do our best. And after a lot of effort, we managed to get a hold of PET tracer that can image innervation of the substrate. This is something that mechanistically has interest for me. The veins go next to the arteries, but also next to the nerves. And it's unclear the role that nerves play into arrhythmogenesis, so we're going to image with carbon-11 hydroxyephedrine PET scans that map sympathetic innervation of the substrate along with CTAs. So to conclude, I hope I convinced you that the cardiac veins represent a unique therapeutic opportunity in cardiac EP, and they allow us to target and map different cardiac arrhythmias. I did not mention vein of Marshall alcohol, but it's something that is very useful for pain, mitral flutter, and persistent AFib, and to target inaccessible intramural ventricular arrhythmias in the LV summit and substrates, and as well as large substrate ablation in VT with structural heart disease. Thank you very much for your attention.